shawl. This is called the award. This is the and Professor Ramachandran will give the memento. It is Lord Krishna. It's a proud privilege for an Indian doctor who has never been trained in any other country. He has visited some countries, but he has not been trained in Mayo Clinic, not in Stanford, doing wonderful work equivalent to, if not excelling, the American doctors. It's a proud privilege for the KG Foundation to give away this award on a very momentous day, this red letter day in the annals of KG Hospital as well as his own life. Thank you very much. Give a big applause. We'll close this ceremony. This guest of honor today has come at our invitation. He said, "How come you're felicitating me?" I said, "No, it came into my mind that because I have not met him before. Being a human being is a great privilege. In God's lakhs of creation, being a doctor is his choice. Being a doctor teacher, you're all doctor teachers. You're not just simple doctors. Doctor teacher is supposed to be much more noble profession. All of us are his master's creations. His master's creations. What we speak is his master's voice. HMV record lam paathirukeenga. His master's voice. So what we speak is God's voice. If you say that you will live, he will live. If you say you won't live, you won't live. Because you are talking his words, you are doing his work. So you're all his pieces, master's pieces. But you must become a masterpiece. You become a masterpiece. Here is a masterpiece. He's a role model for many of the young postgraduates who are sitting here. From a very small town, he grew and he did his MBBS in Mumbai, MD Ortho in Mumbai, College of Physicians, MS Ortho, University of Bombay, DPNB Orthopedic, National Board of Examinations, Diploma on Tissue Banking, National University of Singapore, member of Musculoskeletal Tumor Society of North America, member of India Orthopedic Association, Indian Society of Oncology, founding member of Indian Musculoskeletal Oncological Society, teaching faculty of orthopedics at SNDT College, reviewer of clinical orthopedics and related Journal of Bone and Joint Surgery, independent non-executive director of Z Team of Educational Company of reputed Z Group, lecturer in KEM Hospital, consultant orthopedic oncologist in Tata Memorial Hospital for 10 years, consultant orthopedic oncologist. This is a new terminology I learned recently, orthopedic oncologist at Hinduja Hospital Medical Research Center from 2010 to 2016 now. He has received gold medals in MBBS or gold medals in orthopedic surgery, gold medal in best paper presentation, Society Book Award for the current concepts, DNA Winners Award of Excellence in Surgical Oncology 2016. He has contributed articles and reviews in 69 publications on important topics, and he has published 2 textbooks, Osteosarcoma and Current Concepts of Bone and Soft Tissue Tumors. He has contributed to book chapters of 2 Indian publications, Foot Ankle Surgery, Limb Salvage Osteosarcoma, Computer-Aided Mega Endo Processes, presently doing or associated with 7 ongoing projects, development of indigenous modular titanium prosthetic system for reconstruction of the tumor-related defects jointly by IIT Bombay, evaluation of curcumin formulation and ashwagandha extract in the management of advanced osteosarcoma, native medicine, efficacy of pasteurization of resected tumor-bearing bone, freeze it, irradiate it, put it back again. In reimplantation and surgical treatment of malignant bone disease, is vitamin D an etiological factor for causing giant cell bone tumor, grading of chondrosarcomas using PET scan, making an improved needle core biopsy associated with IIT Bombay, converting 20 X-rays to 30 bone models, pioneered the technique of obtaining allograft of limb saving surgery, helped to evolve and develop technique, trained several currently practicing orthopedic oncologists of the country, helped them and mentor develop the Biomedical Engineering Incubation Center IIT Bombay, pioneered V-Care to start a sarcoma patient support Spandan. Here comes our awardee of the day today. We always recognize personalities. Usually the government of India recognizes maybe sports personalities, about 20 or 30 people every year, and 50 to 60 Padma Shri Pratar. It's a country of 123 crore people. There are achievers great achievers who go unnoticed, unsung heroes. So KG Foundation has been recognizing some of these heroes for the past 20 years, starting from Michael DeBakey, not Michael DeBakey, his name is Christian Barnard, who did the first transplantation. And one of the awardees is APJ Abdul Kalam himself, sir. He was also the first awardee of the Personality of the Decade Award. He was so happy. At that time he had received Bharat Ratna. Still he came to KG Foundation because which is very close to his heart. And we have recognized many doctors, eminent personalities, including B. Ramamurthy, Panda of Asian Heart Foundation, and also the space scientist, Mr. Nambiar. So many people we have recognized. So I thought fit that we'll have to find out how this gentleman, instead of being contained in a bird cage, he breaks free and becomes a red bird. You know, you would have seen this particular emblem, which is called as the Personality of the Decade Award. That red bird is the sign of a personality who has risen above the ordinary people by making an extraordinary contribution to the country. This concept symbolizes the singular bird in the red that ahead of its flock. Kriya Sakti. A lot of people, the awardees list is about 35, 40, so I am not going to read it. Here comes the special awardee today. He has been selected for KG Endowment Oration and to receive the Personality, the Dynamic Doctor of Excellence of the Decade Award. He is one of the top orthopedic oncologists of the country, and it's a pleasure to welcome him.
All of you for being here on a Saturday afternoon, and that's the most difficult time of the day to actually listen to something which doesn't make too much sense. And I must thank Dr. Bhaktavatssalam for his very, very kind introduction. And I must say that most of what he said is not true. And we all try to do things that seem to be important to us. And it's his kindness that he makes it look as though it's done for the goodness of humanity. In this 1 hour that we have, my aim is to just familiarize you with what I do. And also give you an insight of what kind of development is possible today in India, and probably encourage some of you to take on from where we would be leaving. I'm sure most of you do not even believe that bone can have tumors. In fact, when I first told my wife that I want to specialize in bone tumors, she said, "Do you mean you get tumors in bone?" So most people have never heard anybody, or they don't know anybody in their friends or family who's ever suffered from a bone tumor. These are rare. And because these are rare, not much attention has been paid for it. We have much bigger problems. We've got malaria, we've got tuberculosis, we've got the other kinds of cancer related to tobacco. So these tumors didn't become important. Now what do these bone tumors do? Now that we know that they exist, they grow inside the bone, they weaken the bone, and when they weaken the bone sufficiently, you would get fractures. Therefore, they would prevent somebody from walking. If these tumors are malignant, then we call them sarcomas. Just like you have carcinomas which come from the epithelial linings, what comes from the supporting structure is a sarcoma. And you can get sarcomas coming from bone as well as from the other soft tissues, what are called as soft tissue sarcomas. And both these kinds of cancers are exceedingly rare. The danger with sarcomas is that they can spread. And unlike the carcinomas which go to lymph nodes, sarcomas actually travel to lungs mainly. 95% of the time, if they travel elsewhere, it would be the lung, and 5% of the time it would be the bone. So the main danger has been how to battle sarcomas, because they used to go or spread very quickly. Now benign tumors also grow in bone much the same way as malignant tumors grow. And knowing how people in India are, we delay the presentation to the doctors. They sometimes grow to a big size, they can still cause fractures, and you get huge masses at times that you require to remove them. But fortunately, most benign tumors don't require the bone to be removed, unlike the malignant tumors. And you can just scrape the tumor off, and you can reconstruct that cavity with various methods. You can use bone, you can use cement, you can use a combination. And initially this used to be done by general orthopedic surgeons, but now we know that the recurrence rates in the hand of general orthopedic surgeons is almost 40%, whereas if it is done at specialized centers which are trained in doing these cases, your recurrence rates are 10% and lower. There's a lot of technology used. You can see this is the argon plasma cautery, which we borrowed from our GI surgeons who use it to arrest bleeding from the liver surface, and we use it to cauterize the bone. And this is a replacement for phenol, which used to be used in the olden days to cauterize the bone. It's a lot safer and is as effective. Now, this particular talk in the next 1 hour is not going to be about benign tumors at all. I'm only going to talk about sarcomas, which have been a much bigger challenge. And they have been a much bigger challenge simply because they mainly affect the young. The main age group is between 10 and 25, unlike the other cancers which come in the old age. And because they affect the young, there is even more need to do something nice about it. You can't amputate these people, you can't let them slip into the lower strata of society by making them handicapped. So there was an incentive for us to get into these fields. Because knee is the fastest growing region of the human body, most of these sarcomas, or almost 70% of tumors in the bone, would come around the knee. And it's not surprising that they come at the age of 10 to 25, which is the time at which the body grows the fastest. So maybe one cell goes wrong, and that's probably what causes the sarcoma. But put together, bone and soft tissue sarcomas are just about 2.5% of all cancer. And even at a big hospital like Tata Memorial Hospital, which sees thousands of cancer patients every year, for every 100 patients, there are only 2 cases, which would be either bone or soft tissue. And therefore, for a long time, this used to be just one other cancer which was being treated without any importance given to it. But you can, if you see very carefully, look at the results today. This is a patient with an osteosarcoma. You can see that we have not done an amputation. We have removed the sarcoma. We have reconstructed the bone with a prosthesis. This patient walks so normally that she was offered a modeling assignment. Not known to the people who offered her that she's got a big scar on the knee and that she's a survivor of a deadly disease like osteosarcoma. Now, no, she was offered modeling. And I'm just telling you that today you will find lots of these people moving around and you would not know that they have been treated for a deadly cancer like osteosarcoma. Now, it is important to know how we have reached this stage. And I always go back to this slide because it is very humbling to know that these were very difficult to treat. There was a big meeting in 1920 and a very famous surgeon concluded that meeting about sarcomas by saying that if you operate, they die. If you do not operate, they die. And he says this meeting should be concluded with prayers. And this was because even if you did an amputation, they died of lung metastasis. And it doesn't matter what you did for them, they would die. So finally there was radiation, didn't work for it. There was no chemotherapy for it. So finally you said that it's a death sentence when you were diagnosed with something like an osteosarcoma. What changed the things were the high-dose methotrexate chemotherapy which came in the 70s. And Dr. Norman Jaffe from MD Anderson Institute actually showed this, that if you use doses which were about 1,000 times of what were used in conventional cancer, sarcomas begin to respond to it. So they are not chemo insensitive, they are chemo resistant. And if you were able to protect the patient during this time when you are giving such a high dose of chemotherapy and rescue them with rescue factors, then it was possible to get this sarcoma under control. And now this was a change because patients started living, which was unbelievable in those days in the 70s. So if you look at the statistics, if you just did an amputation before 1970, about 15 to 20% would live, and probably God's will, as we said. We didn't know why they lived, but some of them lived. After 1970, it was exactly the reverse. 80% of them would live, and only 20% of them would succumb to disease. So the whole thing changed with the advent of chemotherapy. Now, because chemotherapy was going to make these patients live, and because these were all youngsters, surgical technology also led to improvement in our surgical techniques. So we were now able to do limb saving surgeries instead of doing amputations, which used to be the usual things done in the past. Now, the big question which everybody asked in those days was that if we did a limb saving surgery for somebody with bone cancer, are we going to compromise his chance of being cured of the cancer? And this was a big fear. Okay, I don't want limb saving surgery, I'll go for an amputation, but I want to live, is how people used to think. So there were a lot of studies, and if you see these graphs, you can see there's actually no difference. If you had a distal femur osteosarcoma, whether you did an above knee amputation or whether you did a limb saving surgery, the local recurrence as well as the survival was exactly the same. If you did a hip disarticulation, which is one joint above, you didn't get local recurrence, but if you see from this graph on the right, the survival did not change. It was still the same. So there was no benefit of doing an amputation compared to a limb saving surgery. So that's how a lot of focus came to limb saving surgery in the West, and with improving technology, limb saving surgeries were done. Now we all know there are two kinds of doctors. There are physicians and there are surgeons, and there will be a war always between the two groups, but we all need each other. Now I'm an orthopedic surgeon. I'm basically qualified as an orthopedic surgeon, and then became specialized into doing tumors, and I'll tell you the whole story of how I came about interested in tumors. Now this is a very good definition which I found, is that a super specialist is a person who knows more and more about less and less. And that's what has happened to us today. So I do only orthopedic oncology, so I can do big joint replacements, but I can't do the standard knee replacements required for arthritis. So we've but it was required because otherwise we would not have made progress in this particular field. So I'm going to, through the next few slides, show you how we have moved from nothing in our country to having absolutely the state of art what we have today. We all are familiar with this. This is India. I mean, this situation you see anywhere, you know that you're familiar with this. We have lots of people struggling for common resources. So there's a crowd everywhere. And we have to use unorthodox methods. Now, if you see on this one moped, which is supposed to carry one person, there are 3 people and 2 goats.
2 goats?
Yes, on one moped. So we are, you can say, abusing the things that we already have, the resources that we have, because if we don't do this, we can't make our ends meet and we can't finish our day's work. So India has been always a country with a lot of innovation and adaptation. We can say it is copying, but we had to copy to indigenize, as you can see, in order to meet the local things. We were always wanting to be the best, but we couldn't afford being the best. So we managed to somehow think that we are still able to get what the West was getting. Sometimes this is the most modern technology that we have, and still in many of our villages, farming is still done by this way. At the other end, you've got big cities which have virtually everything that the West has. So India is not one country. We are a land of many, many countries and enormous diversity in terms of people, in terms of cultures, in terms of technology. So you need to have a kind of an approach which fits everybody. On one side you have this techie who's most modern and technologically savvy, and on the other side you have people who are very simple, common rural folk, but all have the same expectations, that they want to get well from the disease and they want their body parts to function as normally as one can let them function. So this has been the challenge in India. So if I look back as to how we started doing tumors, I can first begin when I first got exposed to tumors in 1993, which is about 23 years ago. I finished my orthopedic post-graduation, and I was offered a chance to do a 6 months fellowship at Tata Memorial Hospital in a unit which was called breast, bone and soft tissue. Because bone and soft tissue was not enough work to qualify as one full service. It was a part of another major service because there used to be a huge volume of breast cancer. So my chief was a general surgical oncologist who was specialized in breast cancer, but there was also some amount of bone and soft tissue tumors being treated, and 80% of the work which was being done was amputation. And when we saw that, I realized that this is one field which requires a huge amount of improvement. I'll tell you an interesting story again.
Yes, please. Yes, please.
In our residency, we were lazy orthopedic residents. You know how orthopedic residents are.
Huh?
They don't like to take histories. They don't like to ask patient questions. So whenever we wanted somebody to do the histories, we would send a medical reference. Because the poor guy would come and take diligently the whole history. I'm sure you have faced that as well.
What's happening here many times.
Yes, Dr. Rao.
Sir, actually I worked in Chitra that Professor Oliathar was developing the Chitra van. And I have seen the same struggle which I have undergone for how many times just change them.
Absolutely.
How many times just change it, and 10 million cycles they go through all these things.